Okay, welcome everybody to the June, nearly July, England and Wales ITP patient support meeting. Just be aware this meeting is being recorded because we've had about 30 odd people, nearly 40 people register, and the people who can't want to see it on YouTube afterwards. So, and it's always nice to go back and refer to things as well. Today, our clinical advisor is also Chair of Trustees, Professor Adrian Newland. Hi, Adrian.
Hi.
Who will be here to answer any of your questions. And we've also got a couple of our other board members here. We've got our senior patient mentor, she hates me saying that, Rhonda Anderson. And we've also got Anthony Hurd, one of our new trustees. And there's some more joining now, so just join them. So,
and for those of us who follow us on Facebook, will see that Anthony is extremely active.
Yes, especially with his Substack. Whatever
yeah, I mean, I think it's important as well to mention that if people have any questions and can't raise them, we don't always have time to cover everything in these sessions. Do write some questions that, if you may have them, down and email them into ITP Support Association HQ, and we can always address them later. We often find we perhaps can't squeeze everything in. So if you've got
there's always people who have questions afterwards, and I will guarantee by 10 o'clock tonight I will have 2 or 3, maybe 4 emails with questions.
And I must say, just talking about Facebook, I always look at the Facebook things. I don't always respond, but there's very occasionally, if there's some fact needs to be correct or put there, I will pop in and just make a comment on that. I don't do it on a very regular basis, but I do keep an eye on the Facebook questions and comments, because I think it's more of a vehicle for you all to talk to each other about that. But just occasionally, if there's something needs correcting or someone's asking for something specific, I will pop in and just say something.
And it's also good, we've got a number of regular faces here as well, which is excellent. Hi everyone. Right, who wants to kick off? Who's got a question they'd like to ask? There must be someone who's... My bad. You're muted, so you'll have to find the unmute button. Bottom left.
Yeah.
That's it.
Yeah. Hi all.
Hiya.
Hi. Hello. I just wanted to ask, that medicine avatrombopag. Have I said it right? Avatrombopag?
Yeah, that's right.
Yeah.
How long does it take to work? And even if you're taking steroids with it, how do you know which one is working? Steroid or avatrombopag?
Well, avatrombopag normally starts to work relatively quickly. And by that, I mean, it's very variable in patients, but most will show some response over the first 3 to 4 weeks. It's often added in on top of someone who's already on steroids. And if you've been on steroids for a period and you've not seen much in the way of response, and the avatrombopag's added, then that will lead to a response. We now give it frequently for patients as more of a second line who failed early treatments. We don't want to leave it to a last resort and try lots of other things first. But equally now, we don't like patients to be on steroids at too high doses for too long. So in general, the treatment will be starting off on a high dose of steroids, waiting to see over 2 to 3 weeks if there's a response. And if there is a response, continuing, but gradually starting to taper the steroids down. If there's no response over that period, to start to taper the steroids down, and then add in something new, which can be a variety of things, but often it will now be avatrombopag or eltrombopag or ramiplostim, one of those. I mean, there are other options as well, and the options that are used will depend very much on your own circumstances, your own physical circumstances, other medical histories, that sort of thing, which we could discuss later if it comes up. But I won't give you a whole lecture on the whole thing now. But
that's fine. Okay, thanks.
Is that okay? Okay. I noticed there's a lady in the chat, Bidania, newly diagnosed in February. Nothing worked until very recently. May we ask what treatment you're on?
I
Hi,
think,
can you hear me?
Yes, we can hear you, yeah.
yes.
So I was diagnosed in February, on the 14th of February, after I took
Yeah.
an antibiotic, which I didn't really need it. I felt I didn't need it. It was just given to me by the pharmacist for what he thought it was pharyngitis. Was just like I coughed a lot, and that's why I had throat pain. Anyway, I was admitted in hospital thinking that in 3, 4, 5 days I was going to be out. They did first line, I think, is IVG, what is called immunoglobulin. Then they gave me platelets. Then 3, 4 days later, nothing was working. They started with avatrombopag. I had, in the meantime, a brain bleed. I bled in the brain. So they had to go again with immunoglobulin, and they up the steroid. So they gave me prednisone,
Prednisolone, yes.
prednisolone, from 60 days up to 90. Then they realized, no, it wasn't working. So they started with rituximab. I had 4 rituximab towards the last month of March, together with romiplastin. Then they sent me on with 3 platelets, and they said, if anything happens, come back to the A&E. So now, after being 2 months in hospital nearly with an average of 2, finally every week I get my blood tested, and they're going up. They're going up. Yes, good. On Wednesday I had 92 platelets, or 95, I can't remember exactly. So they're going up from 8, 11, 12, 9, finally 32, 45, 92, which is good. I just wonder whether I still have a weekly injection of romiplastin, 900 micrograms, I think, as well as I take immunosuppressant. Been taking immunosuppressant for nearly 2 months, since the beginning of April. What is it called? It's called no. So I can't remember now exactly. I'm a bit.
Mycophenolate?
Mycophenolate, yes, mycophenolate. They up it to, instead of 1,000 milligrams at the beginning, were giving me that, and then they started to 2,000 milligrams a day. I just wonder whether it's now a good time to start reducing them after having these good results in the last 4. Not yet.
Well, it's an interesting question. I mean, I'll make 1 or 2 points there. The antibiotics you took, whether you need antibiotics or not, is a moot point. But the general antibiotics you would use for things like pharyngitis are just not associated with thrombocytopenia.
Penicillin, yeah.
They're very rare. They're just very, very rarely associated with thrombocytopenia. And if you have a reaction to a drug that drops the platelet count, in general, once you stop the drug, the count will come up within 2 to 3 weeks. Okay. So your low platelet count was almost certainly related to the infection itself.
I think I was going through some cough and cold. So there was a virus for certain, and also because I wanted to go back to work as soon as possible, I was taking other medications like paracetamol, as well as ibuprofen and naproxen as well. So I think maybe I was mixing too much, but I have an history of APML that I had it in 2020, and that was completely gone. So I was in remission since January 2021. And now I had this one. So they run as well a bone marrow to make sure that there was not relationship between the two, and there's no relationship. But my platelets were always perfect. The only thing it was out of context, which I mentioned to my doctor like very recently, was my my RBC. 4 years, even though I was under the care of the hematologist for my APML, 4 years they were above range, a lot above range. Whilst I was in hospital with all the medication, they entered the range. Now that my platelets are going up again, my red blood cells are going up again. I just wonder whether that is a query that I don't see to find a response. Why I have this trend? What brought my red blood cells higher before? And during the treatments in hospital, they were in range, completely in range. About 4 years, I was with my red blood cells above range.
Okay, let's just make 1 or 2 points out for the rest of the people listening here. APML is a form of leukemia, which is one of the forms that's very serious in the first month or two, but it responds very well to treatment. And once someone's in remission, it's one of the few forms of acute leukemia that you can be fairly certain will be cured. So 3 years out from remission, your bone marrow will be functioning normally. Now, when you have a viral infection, some viral infections affect the bone marrow and stop the bone marrow working properly. Not just the platelets, but it can affect the red cells and the white cells as well. But it affects the platelets. Because it affects the platelet, it affects how the platelets are made. And it makes the bone marrow very resistant to treatments, which is why you had such a poor response in the first few weeks.
Months, 2 months, 50 days, no response.
Okay, 8 weeks. So the reaction of most hematologists in treating someone like that is they'll try one drug and then they'll add another and then they'll add another, which is clearly what they've done. Now, obviously, you've got through that period, and hopefully now your platelets will continue to increase back to normal. And then the question will be, what do they start to tail off? And that'll be down to that'll be a decision for your hematologist who's seeing you, whether he leaves you on the mycophenolate at the dose you're on, whether he leaves you on the on the rimiplostin.
I stopped avatrombopag, I stopped prednisolone, so the only thing I have is romiplostin.
Okay. And mycophenolate. Well, he'll almost certainly want to stop one of those at some stage, but he'll probably wait, I would assume, although it's very variable because he sees your results, he will actually want to reduce one of those and follow your count. So but he will probably wait till your count's over 100 and established there, and then he'll start to tail one of them off. But I think what you have illustrated as the difficulty of treating ITP when it presents acutely following an infection.
Okay. At what stage we can consider my my IPT chronic or not?
We normally discuss chronic ITP after 12 months if it's not responded to treatment, but yours is clearly responding to treatment.
Because I thought I wasn't going to, I thought it was taking too long.
I mean, if it hasn't responded at 3 months, we call it progressive ITP. And at 12 months, if it's still not responded, it's called chronic. But obviously, you're still quite early and it's responding. So the question is now, will it continue to respond to the treatments you're on? And then your hematologist will start to tail those off and follow what happens.
Just my last question. Is there a point when somebody with ITP cannot take medication at all, can stop taking medication?
You mean medication for your ITP?
Yeah.
Yes. Well, no, that's what I was saying. What your hematologist will do as you respond will start to tail your drugs off, and with the aim to probably, if your count becomes approaching normal, to stop them completely. That's what we try to do.
Thank you so much, Doctor. Thank you.
Because obviously all drugs have side effects, and we want to reduce exposure to that for as much as possible.
And the heart.
Thank you very much, Regina. Thank you.
Thank you. Thanks. Thank you, guys. Bye-bye.
But a very illustrative story, I think. Yeah.
Very good.
It was, I think that I'm part of some studies. They're studying me because it was really bizarre that I wouldn't respond to anything, and they did all the possible tests.
All patients. I mean, someone's just put one on here saying that comment on saying they've been on rimiplostin for 10 years. It's all patients are very individual in the way that they respond. I mean, we found quite early that 1/3 of patients who are on rimiplostin or eltrombopag can be tailed off it and will maintain their counts what we call treatment-free remission. Now, in general, that will occur within the first 6 to 12 months. And what we try and do is if patients have a reasonable response to the treatment, and we find we're having to either reduce the dose or increase the intervals between the injections, then we try and tail it off. Some patients, you find you just have to continue with it. And if they're happy to take an injection once a week or once every 2 weeks, and it maintains the count in a normal lifestyle, that's fine. We're quite happy with that. And in fact, the Romiplastin and Eltrombopag for the majority of patients long term are very side effect free. They're very, very tolerable treatments.
Romiplastin's got not very tolerable.
Okay, it's very variable. Shall we move on to someone else?
Thank you. Thanks.
Right. Next person. Any other questions? Anyone want to put their hand up or? Right. I had an email today, Adrian.
Yeah.
Whilst we're waiting for someone to come through, that they had a viral infection before they went on holiday. They was cleared to go on holiday. They're now in Antigua, and then all of a sudden they started having bleeding from the gums, etc. And went into hospital. Their count was 3.
Yes.
That they've now been given IVIG where they are, and it's now up to 16. But they say the local hospital there is saying they can't fly back until their count's over 80. Is it that high? I thought it was about as long as it was over 30 or something.
Yes, most people would be quite happy with a flight with a platelet count of over 30. Modern planes are properly pressurized, and they don't put they don't impose any sort of stressors like that. So in general, once there's a response and the count's going up and the bleeding stopped, once the count's over 30, it would be best to what we call scoop and run.
Yeah, scoop and run.
Scoop and run.
Yeah. Okay, great stuff. Rhonda, you got your hand up.
Yes, my husband was a private pilot, and when he was active in the Support Association, he researched all of that about flying, and there was nothing that, a lot of people say, oh, you can't fly if you've got low platelets, but he couldn't find any research that said that you couldn't fly or shouldn't fly if you have low platelets. So, I mean, you would obviously have to consider that with the advice of your medical team and so on. But there doesn't seem to be any documented research to say that low platelets are a danger for if you're flying.
You're absolutely right, Rhonda. And with the reason we tend to take 30 as a cutoff is that below 30, some patients will bruise or bleed spontaneously. And so not everyone, and quite a few don't. Some people can run counts in the mid-teens without having problems with bleeding. But in general, I think in many ways to cover from a medical legal point of view, we tend to say if the count's above 30, we know there's the chance of spontaneous bleeding or bruising, unless there's another problem. And obviously there's some problems make you more susceptible to bleeding. But in pure ITP, if the count's above 30, spontaneous bleeding is very remote. And we would say at that stage, we don't see an issue with flying. But I agree with you that for a patient who's not showing any signs of bleeding, if the count's less than that, I don't think there's an issue. But one has to just be super careful.
Okay. Thank you. Trevor Ricks, you got your hand up, sir.
Yes, thank you. This is my first time here. My son was diagnosed with Crohn's when he was a teenager, and I was diagnosed with Crohn's at age 69. My situation was that I had to have a semi-emergency ileocecal resection.
Yes.
Which went well. And thereafter, I've been on steroid budesonide. 3 milligrams initially 3 times a day, over the years reducing down to I'm now on 3 milligrams a day every other day. But my question is, ever soon after being put on that steroid, I experienced fragile skin and lots of bruising on my forearms. My consultant, I've asked him several times, he's adamant that it's not a side effect of the steroid because he says it's not absorbed. But recently, I put the same question to a dermatologist who I saw for another reason, who is adamant that it is a side effect. What do you think?
It's a side effect of the steroids. Long-term use of steroids does thin the subcutaneous tissue of the arms and makes the capillaries a little bit more fragile, and so you get a bit more bruising. Now, that's not related to a low platelet count. You can bruise like that with a normal platelet count. Now, most people as they get older show these purpura. It used to have the rather offensive term of senile purpura. All that meant was you were getting older and you were showing bruising on your skin. Now, that happens in normal people. It's because as you get older, your subcutaneous tissue, the subcutaneous fat that protects the blood vessels, gradually thins. Now, the steroids accelerate that thinning and can make worse that type of bruising. So, yes, I mean, the sort of dose of steroid you're on is very low, but you've been on it for an awfully long time, and that will have had an effect. So I agree with your dermatologist there. It will have contributed to that.
Thank you. So the consultant in our last conversation is suggesting I might be best to come off the steroid anyway, because my Crohn's is well controlled.
Yes.
I don't have any symptoms apart from diarrhea about every 10 days. So I'm quite happy as far as that goes. If I do come off the steroid, will the fragile skin improve at all?
It'll improve up to a point, but there will still be some element of it there because of your age, to be honest.
Yeah.
So it'll not go away, but it may improve up to a point. But certainly, if you're going to stop the steroids, you've obviously done a lot of it, the preliminaries already, by reducing the dose. And this goes for patients with ITP who've been on long-term steroids is that you reduce it very, very slowly, because when we take steroids, that suppresses the body producing its own steroids. And what we want to do is encourage the glands in the body that produce steroids, the adrenal glands, to start working properly again. So we like to reduce, particularly for people who've been on it for a long period, reduce the steroids over weeks, if not months, if they've been on it for a long time, slowly reducing the dose, increasing the intervals, and that allows the body's own production of steroids to start kicking in again. Because certainly, if you suddenly stop the steroids, your body is actually not producing any, and that can have quite marked effects, particularly extreme tiredness and exhaustion and things like that. So yes, I would encourage you to stop it if you don't need it for medical reasons, but continue to stop it, tail it off very slowly as you clearly have been.
Thank you. I've had lots of skin tears over the years, including being wounded 3 times in hospital. So I have to be extremely careful. So thank you very much.
That's okay. The skin becomes very, very fragile, and the sort of bumps and scratches that wouldn't affect normal people can tear it. The skin becomes almost like sort of Kleenex paper that tears very, very readily.
Thank you.
Thank you,
Rhonda,
Trevor. Thank you.
Rhonda, I think
you've got your hand up.
Yes, I just wanted to add to that I have this problem too, even though I haven't been on steroids for very long, but in the past I have, and I've completely stopped them now for many, many years. but I do have the fragile skin. So if I start doing any housework or anything, which I do obviously, I only have to bump myself and I get a bruise and I get these tears, and anything that I do, anything that I touch, I've got bitten by blackberries today. I mean, anybody would get that, but mine was very slight and I've got that injury. Also, I'd just like to say as a general point to all the people who are on this call tonight, to say that when you are on steroids, you must always find out about them and about the effects that they do have, because I have a history in my family of osteoporosis, and steroids can exacerbate that too as you get older. You know, women have it more because of the hormones and so on, but men do also get osteoporosis, whether they've had steroids or not as common as in women. And so you need to take steps to find out about that as well, because as we get older, we often have more reasons to fall and so on. And it can be very devastating to your health if you break a hip or an arm or a shoulder or something. So it is very wise to look this up, to talk to your doctor about it, and to be taking preventatives for that. And I think that Adrian might have something to say about how much steroid doctors are prescribing these days and how quickly they're trying to get patients off them. In the old days, patients, I think, were left on steroids a lot longer than they tend to be today.
Yes, I think that was the point I was trying to make for both the last two answers, that we try to minimize steroids because we gave people too much steroids in the past because it was effective, but it's only temporarily effective in quite a few, although in some it works completely. Now, there was one, Clive Marlowe's wife had a hand up, but I'm just going to make one point here. There was one of the questioners, Anne Aspen, put a comment up about her granddaughter with ITP, who they were talking about whether this is chronic, and I think she was diagnosed she's been diagnosed for 2 months, and certainly within 2 months children can still spontaneously recover. We call it progressive after about 3 months, and as I said, they don't call it chronic until 12. The majority of children do get better, but a small percentage, probably slightly less than 1 in 5, will go on to develop more chronic ITP, although a very small number of those have counts that are so low that they're of a risk. Although, as you quite rightly said, it's mainly adults here today, the association does have a keen interest in paediatric ITP. We support the Paediatric ITP registry. We usually have a session at our convention on paediatric ITP, and as Anthony has said in his response on there, we have quite a number of things on the YouTube channel, and John Granger, who's one of our medical experts, who's a paediatrician with a particular interest in ITP in children based in Manchester, has written for us as well. And as Anthony has said, there is something on the website from John about ITP in childhood. But certainly, if you have more specific questions, if you just drop a text in, an email in, we can pass it on to John or one of the other paediatric experts and get them to respond to you specifically on that.
Okay.
Does that help a little bit? You don't seem to be muted, but I still can't hear you.
Yeah, we can't hear you.
No, my lip reading isn't that good.
Yeah. If you have any more questions, and just put it in the chat.
Okay. Well, hopefully that gives you some things to work on.
Yeah.
But certainly sorry to hear about your granddaughter. It's very worrying.
Sorry, can you hear me now?
We can now. Yes. Go on.
Thank you. IT support. But yeah, thank you. Let's say this is a new journey for my daughter and myself, and for us as a family, because our granddaughter's only been diagnosed 2 months ago, and her platelets are as low as, well, they went as low as 3, but they've gone back to 8. And this is where I was particularly interested in what you're saying, Adrian, in terms of the 3-month window being progressive, because the advice that we've been had is that potentially the next consultancy is when we're finding out whether it's chronic. So this helps us a lot, actually. And thank you for the offer as well of following up with further questions, because it's so new.
You can still see spontaneous recovery within 12 months. It becomes less usual the longer it goes on, but we wouldn't consider it to be chronic until it hits 12 months. We used to call 6 months as chronic, but quite a long time ago, that definition was changed and extended to 12, just because we were seeing a smaller number of spontaneous recoveries there. So fingers crossed, but please get in touch with us and we can deal with this on the side as well if you have further worries and specific problems.
Thank you so much. It actually means the world, and nice to meet you all.
Thank you very much, Anthony, you got your hand up, sir. Sorry, Anthony, I'm just going to go to Mrs. Marlowe first. All right, she had it up first. Right.
You'll need to take yourself off mute.
Marlowe, you're muted.
Take yourself off mute.
There we go.
That's it. Well done, Clive.
Cracked it.
Yeah. I've had CLL and ITP for years now, and my CLL is active and I take chemo for it. But I've recently seen my consultant and he says I now have low-level myeloma, and I'm not really sure how that fits into the pattern of what I've already got.
It's to tease that out a little bit. We see ITP. I mean, in many leukemias, the platelet count is low because of the impact on the bone marrow. But we know that in CLL, the chronic lymphocytic leukemia, about 10% will show an immune thrombocytopenia. Now, in general, the treatment for that is to treat the CLL. And actually, some of the treatments of the CLL are immune suppressive anyway. There are some patients where they'll combine treatment of the CLL with a treatment to put the platelet count up, one of the thrombopoietins or something like that. I mean, it's very variable. With regard to the myeloma, it's a different form of bone marrow malignancy. They're both caused by impact on what we call the B cells. These are the immune cells within the body. Again, it's low-level myeloma is, although relatively rare, it's recognized in patients and often doesn't require any treatment at all. And it really needs your hematologist who will actually see the results to discuss the impact of that. We don't usually see ITP in association with myeloma. It's more associated with the CLL side of things, and that's probably just an unfortunate development. But in general, low-level myeloma is something that in the majority of patients we always follow and never treat, don't need to treat.
Right, okay. The reason that it sort of come to light, because I've asked about it, is because I now get a great deal of pain in my legs and bones, ankles and shoulders when I do much in the way of exercise. When I say exercise, it's a long time since I've been able to do Pilates or yoga or anything. This is just general walking around, housekeeping, that sort of thing.
Yes. I mean, that to be honest, is not a question I can answer, because it depends on things like the level of your white count and what your treatment is and that sort of thing. But it's probably related more to the CLL and the treatment rather than certainly the ITP, which isn't just necessarily associated with that.
Right. So is it a condition that will progress, or does it progress rapidly, or does it stay fairly stable?
Which condition are you talking about?
Well, with the ITP and the CLL, I've had it so long, I know all there is to know about it.
I mean, the myeloma side of things, in general, when it's low grade, is something that's usually very benign and doesn't progress rapidly. In fact, many, they don't progress at all. The vast majority don't progress at all.
Right. Oh, that's interesting. You know, having got on top of all the ITP and the CLL, it's like something new to find out.
I know. It is something new that's almost certainly unrelated to the other two things. It's just an extremely unfortunate development, to put it mildly. Yeah.
That's me.
Good to see you again.
Sorry to hear that. Anyway, I hope that helps a bit.
Thank you very much, Prof. Anthony, you got your hand up, sir.
Yeah, just a very quick contribution, really, that most people on here may know that I'm on mycophenolate mofetil. I've been on that since 2016. Platelet counts are normal, so it's been very good for me. But one side effect of mycophenolate is that you're more prone to skin cancers. So with the very hot summer we've already had, I mean, we're going up to 31s, 32s again next week. It's very important to take care of yourself in the sun, you know, even for folks that are not on mycophenolate. You know, we're all very prone to going a bit crackers when the sun comes out in the UK, aren't we? So be very, very careful. I mean, I wear factor 50, wear a hat, and sunglasses, very important, because the eyes are really vulnerable to sun. They're more vulnerable, believe it or not, than our skin. One thing that puts it in perspective is to get our daily vitamin D requirement from the sun, we need 10 to 15 minutes exposure to sunlight to get our daily vitamin D requirements. So you can see how dangerous it can be if you're out there for too long. So, you know, just be very careful in this hot summer we're already at. I think all the care you can, but obviously enjoy it as well.
Both those are very, very interesting points, and I think I'd reiterate that. I mean, we know for drugs like mycophenolate that are used in conditions like organ transplantation, because they suppress the immunity, that they are associated with skin cancers, and we know that skin cancers are particularly common in very hot areas, in Australia in particular. And I had to see a dermatologist about some other trivial condition, and she looked at the top of my head, and as you can see, the top of my head probably gets a lot of exposure to the sun for some reason, and said that I was showing sun damage. So said I've got to wear it covered up. So gave me some treatment to try and remove this, which I have done, so my skin's back to normal. But I now religiously wear. I'm one of these old men who walks around with a baseball hat. Sort of thing that I used to look at and say, you can't possibly, how could someone wear a baseball hat at his age wandering around the park? I shall get myself a sun hat as well, but I think it is very important. In this weather, a bit of exposure, bare arms like that, will give you your sort of vitamin D, but certainly during the winter, I take a vitamin D supplement every evening. Good vitamin D levels are very important for to maintain your good basic immunity. And I can certainly, and without wanting to be a health food crank, vitamin D isn't that at all. It's a very good supplement to take.
Yes, I tend to do that as well, because there are very few foods that actually contain vitamin D for us to manufacture the vitamin D that we don't get in the winter months here. But on one other final thing, also stay well hydrated. That's another big one that we all should be drinking 2 to 2.5 litres a day. So it's another one to throw in there. But, you know, just enjoy the sun, but, you know, be very sensible. That's it.
Okay, we've got a couple of questions as well in the chat. One from Adele.
I was just about to comment on that one. I just got it, pulled it up in front of me now.
I've been recently diagnosed with ITP after 2 occasions in A&E with platelet counts of 9, had steroids and now on L-Trombopac after the steroids failed. Platelets went up to 44, but then last week went back down. I've had the dosage up to 75 milligrams. What are my options if this doesn't increase my platelets this week or in the coming weeks, to be perfectly honest? Adrian.
It depends what level the platelet count fell back to. I assume by went back down, it probably means it went back down a fair way. And certainly 75 is a very reasonable dose of L-Trombopag, and you want to see over 2 or 3 weeks what the response to that is. What we do find is that people may respond to Ramiprostin or Avatrombopag who've actually failed or had a poor response to L-Trombopag. To be honest, if the platelet count stays above 30 on a reasonable dose, then there's no point in pushing it any further, because I said, to answer one of the points earlier, over 30, spontaneous bleeding and bruising are unlikely, and it's better to have a response to develop what we would call a hemostatically normal, reasonable platelet count without exposing yourself to too high a dose of drugs with all the side effects that are potentially associated with that. So I would see over the next 3 or 4 weeks what happens to the platelets on a dose of 75. If that hasn't responded, if that's still bouncing up and down and dropping to levels where it's considered to be a bit of a risk, the options are either changing on to another form of thrombopoietin or to adding something in like the mycophenolate that Anthony was talking about earlier, or using a short course of rituximab. So there are options at that level, but the fact that you've shown the response to L-Trombopag is actually a very good indication that your disease is responsive, which is important.
Originally, I was still on a tailing off of the prednisolone, so I only finished that like not last Monday, the Monday before. So I don't know if it's the balance between the prednisolone and the L-Trombopag, and it could all back down to 24.
It could almost certainly be reflected on the fact that your body was suddenly not used to the level of steroid in your body dropping, and it needs to equilibrate to that. I mean, it could be that you need a very low dose of steroids, so 5-10 milligrams for a period while your body equilibrates. But my feeling is that having stopped it, I would wait to see what the response is to 75 over 3 or 4 weeks, because its likelihood is you stop the steroids, the count often drops and then starts to come back up again. And it would be nice to see if that continues over the next 3 or 4 weeks. And if it does, fine. But certainly, if the count only dropped to 27, I wouldn't panic about that. I would just wait and see what happens, because at that sort of level, it's not of risk to you.
Yeah, the other thing was, I was interested before because in 3 weeks I'm going on holiday to Croatia. So then there was the whole insurance and that kind of thing with regards to that. So it was interesting to listen before.
Okay. I mean, we had a comment about the holidays earlier. What we often suggest for people with lowish counts that have been a bit unstable is to actually take a supply of steroids on holiday. And if you actually develop bruising, to start to take them.
Right.
Maybe not even worry about getting a count done, just start to take them.
Okay. Yeah. Amazing. Thank you.
Okay, thank you, Adele. Heather Stobart's put a comment in there. Can I please ask if it's usual for platelets to increase with a viral infection? This seems to happen for her, as my best results are after she's had a cold.
Yeah, yes. I mean, bizarrely, yes. The platelet, although it's common for the platelet counts to fall with a viral infection, we do actually see the platelet count going up as well. When you get an infection, the body produces its own steroids as part of response to the infection. It produces a whole lot of what we call cytokines. These are the body's, and like an immunoglobulin, these are the body's response to an infection, which in some patients force the count up. And interesting enough, going back to that, I don't really want to mention that dreaded period of COVID and COVID vaccinations, but through the association, we actually recorded what happened to platelet counts to members of the association who had a COVID jab. And although we saw the count fall in a small number of patients, not quite as many, but in a significant number of patients, we actually saw the count go bouncing right up. So the body responds in peculiar ways and differently in different people, but certainly in some patients, you will get an infection and see the count shoot up. So yeah, we see that. It's not unusual.
Thank you. That makes sense.
Yeah, on the thing about the COVID jab, Elaine has just said her count went up after she had her COVID jab.
Yes.
So that proves the point.
We saw that in a number of people.
We did, yes, we did. Rhonda?
Yes, hello again. I had that experience as well. I was in Australia and I got this nasty virus, throat and cough and what have you. And I took my emergency antibiotics because I have had a splenectomy. So I always carry my emergency supply with me. And I asked advice and I was told I should take them, which I did. And I had an appointment with my haematologist shortly after I got back, and I thought, I know what's going to happen. They're going to say everything's gone down low again and want to put me on steroids. It was the exact opposite. They had gone up to over 800. And they put me on aspirin because I had so much. And the consultant called me in. He didn't leave me to one of his assistants. He called me in himself and he said, I was actually going to discharge you today, but I can't now because this has happened. So anyway, after the next time I went, 3 months' time or something like that, it was all sort of back down to a sensible level. So yes, people do have different experiences up and down, and sometimes you expect them to go down and they go up, and the complete opposite. So they do have a bit of a will of their own.
That's true. Thank you, Ron.
Just before we get on to the next one, there was also a comment in the chat after my discussion with Trevor Ricks about his very fragile skin from one of the listeners, Trevor Johnson.
Yeah, Bentley dressings. Yeah, I was just going to say.
He was talking about those. About the dressings that are very light and easily removable. So it is worthwhile. You don't want to have the old elastoplast that you rip off your skin with it. That affects us all. And I think that's a very good point just to bear in mind. Certainly as you get older, and if the skin's getting a bit fragile, then those sort of easily removable dressings are worth considering. And I think that's a very good point. Thanks, Trevor, for putting that in.
Yeah, Trevor's also put another interesting point on. I noticed this across the 15 years he's had ITP. It's short-lived and is only a small uplift, circa 3 to 4 to 10 to 11, but it does happen. Whether it's usual, who knows? But he's put a really good point here. ITP enjoys defying normal at the best of times, and I love that. That's a great comment. Yeah,
I mean, in children who have ITP, the vast majority get better and will never have any problem again because it's usually post-infection. In adults, ITP can come on in some patients for reasons like a COVID jab and it gets better, or a drug and you stop the drug and it gets better, or an infection and the infection happens. But for a lot of patients, we just don't know what causes it. It is based on your immune system, which is variable in individuals. And I think although a considerable portion of adults can respond to treatments and have reasonable counts that may or may not be normal, I consider ITP in an adult as a chronic disease that ebbs and flows. And those ebbs and flows are variable. You can have a flow with a normal count for months or years, and something can trigger it and it'll drop. You may need treatment for a brief period and then it responds and comes back up again. So that happens to a proportion of patients. In some it doesn't, and you can't predict. As Trevor said, the disease is there to confound us all.
Okay. Beth, did you just put your hand up?
I did, and Bill did as well. Just by the way, he's quite keen to ask a question. I was just wondering what your thoughts are on the fat jab and people that have ITP, and whether there's been any. I'm sure there's been absolutely no research into that. I take romiplastin, and I'm considering doing it, but not at the cost of my health. So I thought I would ask the question.
I have to say, I have no knowledge of that whatsoever. if you're on romiplostin, you get that by an injection. So by taking the fat jab, it's not going to be affected by absorption.
Right.
If I was going to take the fat jab, I would take it at I would use the microdose.
Mm-hmm.
So the microdose works, is maybe not as profound as the full dose, and that allows you to see the impact of the microdose on your body and on your platelet count. In general, I wouldn't actually necessarily expect it to impact on the ITP or your response to romiplostin, but you're quite right. There's no knowledge about it.
Okay.
But
thank you.
But that's my advice. If you're going to do it, my suggestion would be to use the microdosing.
Okay. Thank you.
Bill.
Oh, hi. Yeah, I just wanted to add to the earlier discussion about CLL and ITP, because that's my condition. And so I've done quite a lot of reading on this subject. It's actually nothing like 10% of people with CLL have ITP, something like more 1 to 5%. And from what I've read, the general advice is to treat the complication and not the CLL. And the reason for that is quite often the treatment of the CLL can cause ITP complications in itself. So unless the treatment of the complications doesn't work, so in my case it was rituximab, or then you might contemplate using the big guns of CLL treatment.
Sure.
So there's just a nuance just on what was said earlier. I just wanted to that there isn't a lot of research on this subject because it's such a rare combination of diseases, but that seems to be generally what I'm being told.
Yeah, I would entirely agree with that. If you've got, I mean, the majority of patients with CLL, or a significant proportion, require no treatment. And if you develop ITP on top of that, there's no point in treating the CLL, as you quite rightly say. You would treat the platelet count. You'd treat that. I mean, romiplostin actually may have an impact on the CLL because it affects those B cells, those immune cells that impact on CLL. But no, you're entirely right. You treat the symptoms, the bleeding, because of the platelet count, if indeed you get bleeding. I think the point I was making earlier, and I shouldn't have, I should have maybe been a bit more expansive about that, is that in patients with severe CLL that's associated with ITP, often treating the CLL will bring the platelet count up. But I think, thanks for clarifying that, because the point you made is absolutely right.
Okay.
Thank you, Bill.
Okay.
There's another one on there, going back to the COVID bit, and I know you've got the answer for this, Adrian. Did we see an increase in people developing ITP after having the COVID vaccine?
That's a really interesting point. I mean, the ITP occurs in 4 patients per 100,000 of the normal population. Now, or up to between 4 and 10. Now, we saw in the COVID jab, for both, it was slightly different with the 2 initial ones, the Pfizer and the AstraZeneca jabs. Thrombocytopenia was seen in around 10 to 15 per million patients. So the suggestion from that is, if in the normal population 40 per million get ITP, but following a COVID jab only 15 do, then actually the COVID jab protects you from getting thrombocytopenia. Now, that's actually a facile comment. It's not the case. But actually, the amount of thrombocytopenia seen in people having the jab isn't commoner than the ITP we've historically associated with the normal population. So yes, you get thrombocytopenia with injections. We know that post MMR, post pneumavax, the pneumococcal vaccine. In the vast majority, virtually all, that's transient. Once the early impact of the immune disruption of the immune system from the jab wears off, the platelet count goes up. Sometimes it needs treatment to help it up, sometimes it doesn't. What we did see with post the COVID jab, that the platelet count often went down really too quickly to be associated with developing the immune problem, by which I mean it was seen within days. And we feel that actually what that was doing was highlighting underlying ITP in the patients who were supposedly normal but had a low platelet count without any symptoms because they'd never had a blood test, they'd not no bruising or bleeding. Now, that's a supposition, but it's purely because we know how long it takes a low platelet count to develop post an infection in childhood, post an immunization in normal population, the count coming down. And in some patients with ITP, with post-COVID thrombocytopenia, it dropped absolutely dramatically and very quickly. And we just feel that may have highlighted patients with ITP.
Okay.
What I would say is that patients with COVID, particularly those with severe COVID, a third of those went on to develop thrombocytopenia. And thrombocytopenia in association with COVID was associated with a much worse outlook.
Hence the value of the vaccine.
Hence the value of the vaccine.
Yes, yeah. Okay, and another interesting one, Sarah's put a comment on here. How often, now this, I'm assuming this will vary with everyone, how often should people get their blood count checked?
It depends at what stage your ITP is.
Yeah.
While you're responding, if you want to monitor how quickly the count's coming up, it may be weekly. If you're in hospital, it'll probably be less than that. When you're establishing yourself on something like romiflostin or trombopag, you probably ought to have it once a week. Once the count's normal, once a month. If you're off all treatment, you could have it every 3 or 4 months if you want.
Mm-hmm.
But what we try and emphasize is it's far better to have an open access to your hospital, to your ITP CNS, and if you notice bruising, to go and have a count then, rather than have a count 3 monthly or 4 monthly, because the chance of you coinciding with the count being low with a sporadic visit is quite small.
Okay.
So frequently while you're being established on treatment and showing the response, less frequently once you've responded.
Thank you very much, Adrian. Right, last 2 minutes. Bill, you got your hand up.
Oh, just a quick question and a follow-up from the COVID discussion there and COVID vaccination. I expect if you had a vaccination last autumn, you will have been required to fill in a questionnaire prior to vaccination saying, have you ever had ITP or you currently have ITP? If so, you then got sent off to see a GP or a doctor somewhere before you could have the vaccination. I wondered why the Department of Health, if the issue isn't that substantial, why the Department of Health decided to go down that route.
Because there was a lot of publicity about it, and there was a particularly serious condition called thrombocytopenia with thrombosis. That was the one where patients had major problems, and they were being overly cautious and trying to. The two conditions aren't associated. Thrombocytopenia and thrombosis is an unusual but recognized problem with both the COVID jab, and very unusual but recognized. Thrombocytopenia was also recognized, but as I've said from the figures, very, very remote. But I think they were, because it was something they knew about, they were just covering their tails.
Right. Okay, that's helpful.
Okay, thank you, Bill. Right. Well, 30 seconds to go.
Well, I think as Anthony's last point on there, which I think is a good one, is just highlighting the fact that we're having another of these meetings.
I was just going to say that.
Okay, I'll leave that to you.
Yeah. What I was going to say is our next virtual meeting is coming up next month, and we've got the pleasure of having Dr. Andrew Morgan, a clinical psychologist. I first met Dr. Morgan up at Liverpool when we held a patient in-person meeting with the Liverpool haematology team. It was an excellent presentation. So after that, we invited him down to speak at our annual conference in Manchester back in May. And as a result of that, we've had so much interest. We've asked Andrew to do a couple of these virtual meetings, and he's agreed. And the first one is in July, and Anthony's going to remind me of the date because I haven't got it in front of me.
24th
24th
of July,
well done,
but
both of you.
it's at 6 o'clock, 6 p.m. start.
It is
6
early
p.m.
because
earlier than usual.
He's got children to put.
Okay,
all right.
That's why.
I'd forgotten that.
But
Yes.
please register for it. We've already
6 p.m.
got well over 40 registered.
Yes.
So
and
is amazing.
That's fantastic.
For those of us that
so people send questions in first.
Yes, that's right. Yeah.
Okay, as we finish off, I see Vicky here has put up that her poor teen daughter got ITP after her HPV jab.
Yeah.
Hopefully that was transient. And finishing off, it was again, as Trevor Johnson said, he has to tell the GP what ITP is now. If you consider that there are only 800 new patients with ITP every year in this country, I forget how many GPs there are, 30,000. The majority of GPs will not see a patient with ITP in their entire career, and in their medical training, they would have had probably 15 minutes as part of a lecture, and they were probably asleep during that bit. So that's why the association is important, because we want to make all our members expert patients who can pass on the message to their GPs.
Okay, and just for Vicky and her teenage daughter, we will be publishing a book for young adults and teenagers the week after next. So it will be downloadable from our website then. Yeah. But we will also have hard copies available. So keep a look out on social media. When it's available, write to me and I'll send you a copy. Okay, thank you everyone.
Yeah, brilliant.
Hope you've enjoyed it.
Well done.
Okay.
It's been an excellent meeting. Thank you.
Thank you.
Thank you, Adrian. Thank you.
Bye.
Thank you.
Bye.